Okay, let's dive into this. Here's our roadmap. 1. Classification. 2. Management. 3. Key clinical pearls. 4. Classic exam traps. And 5. A quick recall test.
All right, part 1, classification. So let's lay down the blueprint. What exactly is the Child-Pugh classification? Simply put, it's a standardized, proven system we use to estimate the severity and prognosis of chronic liver disease and cirrhosis. Imagine a patient with a history of heavy alcohol use or chronic hepatitis who suddenly needs an operation. You can't just eyeball them and guess how their liver is going to handle the stress of anesthesia, right? You need hard, objective data. This tool gives surgeons and clinicians a universal language to communicate exactly how sick a patient's liver truly is.
Now, here is the classic textbook framework you need to lock in. The child score uses exactly 5 parameters, and you score each one with 1, 2, or 3 points based on how bad it is. Let's walk through it. First up, total bilirubin. Under 2 milligrams per deciliter gets 1 point, 2 to 3 gets 2 points, and anything over 3, that's 3 points. Next is serum albumin. Now pay close attention here, because this one works backwards. High albumin over 3.5 is good, that scores 1 point. But a low albumin under 2.8 scores a critical 3 points. Then we've got INR, which measures clotting. Under 1.7 is 1 point, 1.7 to 2.3 is 2 points, and over 2.3 is 3 points. Finally, we look at 2 clinical signs, ascites and hepatic encephalopathy. None at all, 1 point each. Mild to moderate symptoms get 2 points, and severe refractory ascites or grade 3 to 4 encephalopathy score 3 points each.
So once you've tallied up the points for all 5 of those parameters, you just sum them up to get your total score. The lowest you can get is 5, and the highest is 15. This total chunks your patient into one of 3 specific classes. Class A is a score of 5 to 6, that's mild or compensated disease. Class B is 7 to 9, meaning significant functional compromise. And Class C, that's a score of 10 to 15, indicating severe decompensated liver disease. Moving right along to Section 2, Management and Clinical Use. Let's shift gears for a second. Let's stop just memorizing facts and start thinking like a surgeon. How do these scores actually dictate what we do on the wards? Take Child-Pugh Class A. With a score of 5 to 6, this patient has generally compensated disease. From a surgical point of view, this is the most reassuring category. They generally tolerate surgery much better than B or C patients. But they aren't totally in the clear. Your management plan still needs to include regular surveillance, treating the underlying liver disease, and of course, always assessing for complications of portal hypertension. They're stable, but you definitely need to keep a watchful eye on them.
Now let's see how things escalate with Child-Pugh Class B. A score of 7 to 9 means significant hepatic dysfunction. The danger level is definitely rising here. These patients have a markedly increased operative and anesthetic risk. If you're even considering elective major surgery, it requires a very careful multidisciplinary risk-benefit discussion. And more importantly, as a clinician, you've got to aggressively optimize these patients before they ever roll into an operating room. You're going to need to manage their ascites, bulk up their nutritional status, correct any coagulopathy, treat encephalopathy, and clear up underlying infections.
And then, we hit Child-Pugh Class C, a score of 10 to 15. This is severe decompensated liver disease. The perioperative mortality risk for these folks is just exceptionally high. So the surgical rule of thumb here is simple and very strict. You must avoid non-essential elective major surgery, wherever possible. The physiological stress of an operation is literally just too much for their failing liver to handle. Instead of planning for surgery, your clinical focus needs to immediately pivot toward assessing them for a liver transplant where appropriate.
And this brilliantly illustrates the immense clinical utility of the Child-Pugh score. Just look at this stark contrast. On one hand, you have Class A, a patient whose liver is compensated enough to generally breeze through a necessary operation safely. On the other hand, Class C, a patient in severe decompensation, where taking them to the OR for an elective procedure could be flat-out fatal. So you see, this score isn't just a number, it's an absolutely crucial guidepost for patient safety.
All right, Section 3, Key Clinical Pearls. I want to share a little insider secret that'll help you chunk this information so you literally never forget it on rounds. The absolute best way to remember the 5 parameters is to visually and conceptually separate them into 2 distinct buckets. Don't just look at it as a random list of 5 things. Think of it as a 3+2 breakdown. You have 3 objective laboratory parameters that you check on the blood work: bilirubin, albumin, and INR. And then you have 2 subjective clinical parameters that you get by physically examining the patient: assessing the belly for ascites, and evaluating their mental status for encephalopathy. 3 labs, 2 exams. Simple as that.
To make it even easier, you can rely on the classic mnemonic. Just remember the letters B, A, I, A, E. That stands for bilirubin, albumin, INR, ascites, and encephalopathy. Seriously, write this acronym at the very top of your scratch paper as soon as you sit down for your exam. B, A, I, A, E. It's a real lifesaver.
Next up, Section 4, Classic Exam Traps.
You know, test writers are incredibly predictable. And what's really interesting about this slide is it highlights the single most common pitfall medical students fall into. Trap number 1. The Child-Pugh score does not use serum creatinine. It's so easy to mix this up because obviously renal function is intimately tied to liver failure. But creatinine is not one of our 5 parameters here. It's a huge component of the MELD score, not Child-Pugh. If you see a multiple choice question offering creatinine as a Child-Pugh parameter, just cross it out immediately. No way.
Trap number 2 relies on you completely confusing the direction of the scale. Now, in some medical grading scales, a higher number is a good thing, like the Glasgow Coma scale, right? But in the Child-Pugh classification, a higher score equals worse liver function. Remember, Class A, the lowest score, is your best-case scenario. Class C, the highest score, is the absolute worst scenario, signaling severe decompensation.
And trap number 3? That's confusing the 2 major liver scoring systems entirely. Let's just compare them head-to-head to isolate the differences. Child-Pugh uses a mix of labs and clinical exams, right? Bilirubin, albumin, INR, ascites, and encephalopathy. The MELD score, or the modern MELD-NA system, is entirely laboratory-based. It shares bilirubin and INR, but then it swaps in creatinine and sodium. MELD completely ignores clinical signs like ascites and encephalopathy. Make sure you keep these 2 systems firmly separated in your mind.
All right, finally, Section 5, the quick recall test.
Okay, we've hammered through the theory. Now it's time to actually apply what we've just reviewed and see if you can synthesize this on the fly. Imagine you're on call. A patient presents for a surgical evaluation with the following profile. Their total bilirubin is 4 milligrams per deciliter. Serum albumin is 2.5 grams per deciliter. Their INR is 2.0. And on physical exam, they have moderate ascites and grade 2 encephalopathy. Take a second. Calculate their points for each parameter, add them up. Got it? What's their total Child-Pugh score?
Did you get 13? Let's quickly break the math down. Bilirubin of 4 is over 3, so that's 3 points. Albumin of 2.5 is under 2.8, so that's another 3 points. And INR of 2.0 falls right in that middle tier, giving us 2 points. Moderate ascites gets 3 points, and grade 2 encephalopathy gives 2 points. 3 plus 3 plus 2 plus 3 plus 2 equals exactly 13.
So the crucial point is how we actually interpret that number 13. Because it falls squarely into the 10 to 15 point range, this patient is firmly categorized as Child-Pugh Class C. They are in severe decompensation, which means elective surgery is completely off the table, and they carry a very high perioperative risk. And that brings us to the end of our explainer. I want to leave you with this final thought. How will recognizing the profound difference between a Class A and a Class C patient actually change your surgical risk assessment on the wards tomorrow? You see, memorizing BEA, AIE isn't just a trick to pass a multiple-choice test. It's about instantly recognizing when a patient is robust enough for the OR, and when taking them to surgery could literally cost them their life. Master this classification, use it diligently, and let it guide your clinical judgment. Keep crushing your studies, and I'll catch you in the next explainer.